What I want staff to understand is that people with disabilities are constantly being told directly and indirectly that we are a problem. More specifically, that we are our own problem. The entire premise of reasonable accommodations is a testament to this. I totally understand there are practical reasons why patients must request reasonable accommodations, but that process still places the burden on disabled patients to repeatedly explain, justify, and negotiate our needs in environments that are built around a very narrow definition of normal. For many of us, that repeated experience can trigger complex trauma responses. We are already intimately familiar with our differences. We do not need those differences unnecessarily pathologized or framed as inconveniences. When every interaction with the healthcare system highlights our otherness, healthcare becomes emotionally exhausting. That is why attitudes and behaviors of frontline healthcare staff matter so much. You are not going to change a patient's disability, physical limitations, or medical complexity, but you can directly influence whether that patient feels respected, safe, and confident that they are receiving equivalent care. Unfortunately, because this was not my first experience navigating inaccessible healthcare, I picked up on subtle, unintended messages very quickly. Before my first mammogram, it felt like I was being hurried through something perfunctory, without adequate care for the quality of the exam, the images, or the results. In hindsight, that feeling was not entirely inaccurate. We were under a time crunch because reasonable accommodations had not been proactively prepared. Hopefully that My Health Online glitch is fixed. I know it was probably surprising to hear how negatively I experienced that appointment, because I appeared pleasant, compliant, and did not immediately complain. The reality is that many disabled patients are used to suppressing discomfort in medical settings because we are accustomed to being viewed as difficult. Honestly, I likely would not have formally complained if I had not later been blindsided by language in the report that essentially implied these were the best images possible for someone like her. That was devastating. During the first mammogram, much of the language being used probably sounded neutral or practical to the staff involved. But from the patient side, it communicated something very different. Repeated comments about how difficult things were, how positioning was not working, or how challenging the exam was made me feel like a burden. Like my body itself was an inconvenience to the clinical staff. I already knew the mammogram would be technically harder. The problem was not the reality of the difficulty. The problem was the lack of proactive, positive communication surrounding it. Without that reassurance, how could I feel confident I was receiving adequate, let alone equivalent care? If your entire experience is hearing, this is difficult, this isn't working, we can't position you right, would you feel confident that the images were adequate? A technician's demeanor has a profound impact on the patient experience, and I believe this interpersonal aspect is often underestimated. After the complaint, the mammogram after my complaint felt completely different. The exam was not physically easier, my disability had not changed, technical challenges were still present. What changed was the communication, preparation, and attitude. The technicians approached the situation with confidence, collaboration and reassurance instead of frustration or defeat. That dramatically changed my trust in the process. Another important difference was transparency. After my trust had already been damaged, I needed confirmation that the images were adequate beyond verbal assurances alone. Having confirmation from the physician that the relevant tissue had been visualized made a huge difference. Because there's truly nothing worse than being verbally assured that everything is fine, only to open a report later whose first lines emphasize limitations and technical struggles. That creates doubt, not only about the report, but about the entire experience and process. Language matters. Certain phrases in reports can be especially triggering for disabled patients because they'll reinforce fears that our care was considered good enough rather than equivalent. Examples that were difficult for me to read included: best possible images were obtained given limitations of patient positioning. And then right after that, within limitations, no suspicious findings. Other examples that might unintentionally create similar reactions include: suboptimal examination was unremarkable, technically challenging study due to, or the blank is poorly visualized. I understand these phrases may have technical or legal importance, and I'm not arguing against medical accuracy. These were all directly lifted from Sutter imaging reports within the last 3 years. What I'm asking is that staff recognize the emotional impact that these phrases can have when they reflect an experience where the patient already felt like a problem, an inconvenience, or a lower standard of care. Final thought is that for many disabled patients, trust in healthcare is fragile because it has been repeatedly damaged. Positive, proactive preparation and communication do not erase the technical challenges of disability, but they do change whether the patient walks away feeling dehumanized or cared for. That difference matters, and it can directly affect whether patients return for future screening, follow medical recommendations, and trust the healthcare system enough to seek care at all.